You can see the participants we have here are Andreas Berman from Siemens. We have Jao Correa from Philips. Vikram Simha from Vital Images, and Robert Taylor from Terra Recon. And so welcome. We're really happy to have you here. And so now with that little bit of interlude, we'll go back to questions. And you know, if you think that one question is best answered by one person, direct it that way. Otherwise we'll moderate.
Yeah.
So go ahead.
So I have a comment or a question, kind of multiple variants of it, but it comes down to one of your statements about islands of productivity. And this is becoming more important because as we use 3D visualization tools to make diagnoses, we are often forced to come up with a way to save what we used as a reference for future comparison. The problem is that almost all of the 3D processing intermediaries are proprietary. And so you're stuck with a problem that those images don't transport. In fact, they may not even store well in your packs, which forces you to maintain this island of productivity thing. And so now if you migrate packs or change vendors or, God forbid, the vendor changes versions. I have one system where we have to keep running a legacy workstation because the current software cannot read the 3D data we've created on the prior version. And so when we want to do a comparison, we literally have to load the old study onto the old workstation and the new study onto the new workstation, and they sit next to each other and we can compare them. This is a problem that we have to come up with an answer to, is what do we do? We have a definition of how to store with the chest x-ray that I looked at, but we don't have for the 3D. And what's even worse now is one of the 3D advanced things that you didn't even bring up is the concept of modality fusion. We're doing more image tracking and modality fusion, and I'm not even sure that anybody would know what to call a fused ultrasound MR image that I used to guide a biopsy. And what do you do with that? Because someone someday is going to say, prove you stuck the needle in something that you can't actually see on one of those modalities because you used a fusion modality to do it.
That's a great question. I'll give a brief introduction to the answer, and then I'll let the vendors give the real answer. To the first question about how do you save the proprietary 3D format data, there is actually a DICOM working group that's dealing with that. The problem is that they don't have a final standard out there that can be implemented, but there is being progress. The second problem also has a similar answer. There's a DICOM working group that's worked on essentially representing the geometric transformation that maps one data set onto the other, and that one, I can't remember the exact status of that. I know they're well along. I think they're further along than the 3D problem because that's much more complex, but there is DICOM work which would allow a standard way to represent that. The vendors probably have a much better handle on those problems, so if one of you four want to tackle that.
And just to put a point on the question, so for example, let's say that I'm doing a 3D, and rather than just saving whatever 3D rendering that I use to make my diagnosis as a JPEG image, I want to be able to save it in such a way that somebody could click on it and then take over and manipulate and make modifications to it. Or if I make measurements, I want to be able to save those in a format that I might be able to have another vendor be able to display. And currently, there's not the mechanism to be able to do that. So I think it's a great question, and I'd love to put that. So Robert, maybe you're at the end. We'll go ahead and start with you, and
okay.
We'd love to get some
yeah, I'll take a run at that one.
On that.
I think that's actually the tip of the iceberg, what you're talking about, because you use if you talk about, if you look at, for example, a chest x-ray and the way you interpreted the image, you have a way to store that. That's the output of a modality. And if you want to talk about storing in a uniform, standard way the output of advanced visualization, you have to treat it as a modality, which means you have to somehow define some kind of common understanding about what that advanced visualization system's doing. And right now, all of that is basically proprietary, and what vendors think is helpful based on feedback. But it goes back to the point about the variability between the results you get from different systems. I mean, there is no standardization of what algorithm should be applied to interpret a stenosis, for example, such that it can be stored in a standardized way. So is it possible to evolve advanced visualization to the point where it's its own modality? I think it might be a bit of a stretch, because it's a very big universe of things that these systems do and that physicians want to use them for, and it could be almost an impossible amount of work to try and standardize every possible interpretation strategy that a physician will apply with a general purpose tool. So although we can work on standards, and it's definitely a valid thing to do, I do think that for a while there's going to be some kind of common denominator, which is capturing the view in a kind of a static image, capturing the measurement, keeping the original thin slices. That much is standardized across different vendors, but then after that, if you want to get back exactly to the state of the system where the diagnosis was made or the interpretation was made, you're definitely going to need a legacy system that can support that. So it's incumbent on us as vendors to have that backward and forward compatibility so that these states can be restored. But it's a very big question. It's not something easily addressed.
I mean, two things here. One is, the question about saving state on DICOM. I think that most vendors provide it. At least I know that we at Vital Images, we enable any saved state image to be pushed to your primary DICOM storage device and store it and retrieve it and bring it back up. On the question of standardization of orientations and segmentation masks, yes, there is a standardization effort in DICOM, but even us as vendors, if we saved our orientations and segmentation mask of a standard patient orientation, like DICOM images are saved, then you have image orientation and image scaling that you can use to reconstruct. Anybody can use to reconstruct a 3D image from a set of slices. I think that would go a long way. But that conversation needs to happen, and everybody needs to agree to a standard space which we use as a reference. I think using the DICOM HFS patient orientation space would be the most logical.
Andreas?
Yeah, I agree actually with what both other speakers said. For us, the challenge is that if I look at the number of applications we are developing at the moment, we will end up with roughly, let's say, probably between 50 and 60 specialized applications that are doing all kinds of different calculations, and standardizing that will be a huge challenge. Nevertheless, I believe we have to put effort into that because I think it's truly important to come to that kind of quality control, which was that's a big issue to us, which was raised earlier, and to also make results from different rendering engines and vendors somewhat comparable. I think where I see that going is that at least, let's say, you can store the results of what you were doing in a presentation state and save that back to the packs. So you have at least a very basic means of later on reviewing and retrieving what were the images that you made your diagnosis on. And what we are, for example, doing is we also store in a DICOM structured report object sort of the results in a structured way, and that can also be brought back, and this is interlinked to the images, so you can use that for quick navigation. The pitfall of that is, of course, that's proprietary again, and we have yet to work on a standard for that.
John?
Yeah, I agree completely with the panel. I think the proprietary issue is really on the way of optimizing the workflow for PACS. But one of the things that we definitely believe is that our PACS should be able to automatically do most of the work and save as a state, so that clinicians, when they use PACS to read studies, they can really have most of the segmentations and analysis done by the advanced visualization software. And if some small adjustments are needed, they should be able to go and manipulate that data and adjust. And that's the workflow that we believe that will make it much easier when you think about the volume of data that we are dealing recently with CT and MR and other modalities as well.
I just want to go back to central archive for a second. Our biggest problem right now, we're being forced to look at thin slice server, basically, because of study loading time. I would have no problem having everything pushed to our archive, but then when the radiologists try and pull up an exam that has 20,000 slices, that slows everything down. I almost think that, maybe it would be up to, the PACS vendor to be able to, some way, load a study, but without that large set. Like load without 3D series or load without large, 100 plus that. Because actually our PACS allows us to select 10 out of 12 series and load them, but then
so
the
radiologist
radiologist
has
has
to be able to do is use your PACS, find the images, use your PACS to mark studies as dictated or not, use it for workflow, but then you want to load up the images into memory somewhere, and then you want to share memory essentially. So you want to, once you've loaded it, use a visualization engine with the information already loaded by your PACS into memory, and then you have a much tighter integration between the two systems. Is that
right.
what you're...
You're right. Basically, what I like is whether there's a separate server or not, actually, doing the processing or not. Just actually the raw. Well, now I don't say raw data, but now we have the 300 plus slice scanners producing up to 20,000 images for some of our CTCAs. I want to be able to just take them and archive them on our PACS, but it's retrieving the exam for the radiologist or a retrieving a referring physician, where they have that large data set where the study won't even load, depending on the PC that they have. Be able to load it from the PACS and just having some sort of functionality in the PACS that allows you to load it without that large series, or simply, by itself. And it has to be like a click or two, not like 10 clicks. We can actually do that, but right now you'd have to sit and pick each series and say, I want to load these series and leave out the 20,000 images.
Yeah, I think that's a good point. In some respects, I'd say that's perhaps a deficiency of DICOM. One thing, at my institution, we built the clinical image viewer, not the PACS. And what we do with those 20,000 thin slice series, we actually have a code in there that if it's a :-D somewhere in the series name, we know that's one of these optional, not routine. And so the clinical image viewer doesn't load those unless there's an extra button that says, I want to see everything. And that's one way to get around it. And I think DICOM probably needs to extend its information model to say, this is not one of the routine things that needs to be seen, and there needs to be a special sauce button that lets you gauge. Because you're right, most of the time you don't need to get at those.
And so for you advanced visualization vendors, is that the first time that you've heard that question asked? And if not, how do you respond to that query? So we're not going to necessarily go and talk and do each question for all four of you, but if any of you want to respond in particular, then let us know. Maybe.
So definitely, I mean, this is a big issue with all customers. So you're not alone in the world, and I think that question of how do you deal with thin slices is also closely interrelated to what are you doing on the front end side. Because if you have something which we sometimes call a unified viewer, where you don't make a difference between your traditional PACS 2D reading and your advanced visualization reading, I think you have the option. It's a challenge for you if you're an IT administrator, but you have the option to store it centrally. And then give the user the opportunity to deal with that as if it was sort of one study. Meaning, what we are doing, for example, is we will offer a possibility to seamlessly and on the fly switch between looking at thin slices or thicker slices. Yeah, so you can vary that from sub-millimeter to 10 or 15 millimeters if you want to, or probably usually you would choose the 5 millimeters. And the trend that we see is that customers, it's not even so much our own recommendation, but customers tend to store the thin slices, and they keep them for various reasons, retrieving priors, doing re-rendering. And I think we as vendors have to offer intelligent mechanisms that you are not bothered by the image load or the network traffic in that, and that on the front end side you can really seamlessly choose between more a 2D reading and an advanced visualization mode. And that's where we are going, definitely.
Thanks.
I mean,
Okay,
I think
Robert and then Vikram.
Yeah, sure. And I know Vikram's going to talk about some of the initiatives underway to try and standardize on fast loading of volumetric data, so I'll leave that one to him. But I think a key point here is that, I mean, something that I saw as a theme through the presentations and we often hear is it's very radiology-centric. You're thinking about PACS as a very key cornerstone of the whole image management system. Well, surely it is, but actually images are no longer only a radiology-centric thing. Radiology certainly generates them, should own them, should control the delivery of them, but access to those images has to be an enterprise-wide aspect of the whole service. So I think that we really need to move away from thinking about the PACS as the curator of all of the image archive, and having some kind of enterprise archive that can store all of the images. PACS becomes one way of accessing that when you're in a diagnostic interpretation mode, but you also need your advanced visualization system to be able to access it, and access it not only within radiology but from wherever else people need to get access to the images. So the separation of storage from interpretation in the context of PACS, I think, is very important. And sites that have adopted a kind of an enterprise DICOM archive strategy and consider that separate from the PACS server actually have a lot of flexibility, and it's a very nice architecture, and Mayo is actually an excellent example of that. The challenge is advanced visualization needs to load gigabytes in seconds or doctors get impatient. So if you're going to have a strategy like that, you really need to think about a very fast pipe out of that archive so we can get the images in 3D and start rendering them as fast as possible.
Thanks. Vikram, quick.
I mean, the quick comment is, we are very aware of this problem. This is not new to us. And yesterday evening, an effort led by JHU and Vital Images, which included a whole bunch of other vendors, including Siemens, Terraricon, Accio, and a whole bunch of other vendors, we discussed this exact problem of how do we have a central archive and enable fast loading of images, or to exclude loading large image data sets if it's not necessary. And there's an ongoing vendor discussion that's going on.
Thanks, Vikram. Okay. Thanks for the question.
Just one more follow-up. I'm going back.
Quick, super quick.
When I go back to the hospital, really is the best solution right now still then separate archive for those slices? And that's the last where I'll leave it. Like, say the next few months.
I didn't quite get the question.
Yeah, right. Can you repeat the question, please?
Is basically right now the best solution just a separate archive for the thin slices right now, period? Because all these things that we're talking about, they're definitely in development.
Well, I think it's theoretically a good solution, but you definitely need to work on how it's going to talk to all the other systems. So right. It may not be so easy. You have to look at all the different subsystems in your institution. But for the longer term, we have to think in those terms, because if you just treat it as a PACS archive, you've restricted your whole access to images enterprise-wide.
And it also raises the question of having a vendor-neutral archive. In other words, should there be one archive that's maybe separate and not specifically tied to a particular advanced visualization vendor or a PACS? The pro of that is that you can achieve better efficiency, you have greater control. The con of that essentially is the fact that many of the advanced visualization rendering and even the PACS systems require proprietary transport mechanisms and proprietary pre-processing of the data. So we're still in a situation where you really need to, it depends really on which PACS system you have and which advanced visualization system that you have, and how and who you want to distribute the images to, as far as what your strategy is for storing thin versus thick data. But thanks for the questions.
Okay, I want to get back to the very beginning of the discussion in regard to this proliferation of specialized workstations to handle very specific analysis capability for the radiologist. Now, I don't disagree with many of things that you have said. On the other hand, are we willing to live with sort of an intermediate state where we have multiple applications running on the PACS workstation with proper context sharing with PACS? Now, the reason I'm bringing this up is we at least have had some limited success with this kind of approach. So, for example, I have 7 PET-CT scanners. They're all read on PACS with complete context sharing and everything, including dictation and the whole 9 yards. I can do 3D visualization. I can do, cardiac analysis. but it all was done really, rather than asking for having this all as part of my PACS application, it's a separate application that shares context. We're about to put on nuclear medicine, which will be on the PACS workstation, and we have Mambo on the PACS workstation, and so on. So I guess the real question is, are we willing to live with sort of a quote-unquote intermediate state where the radiologist can stay in the same seat, okay, but unfortunately we'll have to deal with, probably different user interfaces, which we have to do, but at least you don't have the disconnect of, this workstation over there does that, and there's another workstation over there which does the other thing.
Yeah, I think that's a good point. One question is, do your clinicians also have the same capability at their workstations to be able to have access to multiple applications, or is it more just for a subset of the radiologists or nuclear medicine physicians?
I'm right now speaking primarily about the radiologist, okay? I have to take care of them. I've got 85 attendings, and I got a total of 560. So they're going to get, the service first, because they have to analyze and generate the information for the clinician, the people making the decision, although results are pushed into PACS. So you don't have the full analysis capability, which I'm not sure you want. I mean, they can rotate and so on and do things like that on 3D visualization. The thing they can't do is, take objects on and off and stuff like that. So we have the beginnings of that, but I feel right now that I have to take care of the radiologist first, so they're able to use all the flood of information that's coming into radiology and do a proper analysis with all the imaging modalities that are available to them. And I guess all I'm really telling you here that we have had some success with integration, which from a radiology IT's perspective is ugly, okay? But for the radiologist is an advantage.
Thanks. I'll take that as a comment, and it's really important. So thanks for sharing that. The bottom line really is that one can utilize multiple different vendor solutions all at one workstation by doing context sharing in one way or the other. And one doesn't necessarily need an extremely tight API or an extremely tight integration to still have the functionality and capability to share multiple systems as an intermediate step. And I think that's a good point. And that's what many of us are doing as a compromise as we're heading toward a direction where there's much more seamless sharing as far as memory and sharing as far as efficiencies, and maybe even some more sharing as far as a graphical user interface also. So point well taken. Thanks.
Yeah, Elliot, you did a...
Oh, comment, yes.
Yes. Thank you so much. Actually, we at Philips, we see exactly what you're talking about, and we actually have two different solutions within our PACS portfolio. You can have some productivity tools where you can use straight from your PACS. You can do quick measurements of, for example, stenosis and other lesions. And we also work with the server-side rendering when you want to do the quantification analysis that you need some deeper, advanced visualization tools, and they work side by side. But absolutely, we want to make sure that all those tools are available on your PACS workstation in different levels. But again, you have productivity tools that you can very quickly, like in 2-3 seconds, measure, for example, the percentage of stenosis in the carotid artery. Or you can go deeper into your server-side rendering and really create center line and do something more advanced, such as surgical planning, stent planning, etc.
So you had a comment too, and then Vikram.
Yeah, just I think it's a very good point that you have to take care of radiology first. I mean, that's where the images are interpreted. But that architecture decision that you make at the beginning can have a huge impact down the road. So it's very important to think ahead as well. I mean, a typical real-world situation is you're dealing with potentially multiple hospitals. Some of them may have been acquired into a particular business entity at a later date. They might have different PACS technology, different RIS, different EMR. And if you use a client-server architecture for your visualization, in a format that can be delivered into any of those different vendors' platforms, into all the different ologies, take it outside of radiology, deliver this functionality beyond the interpretation stage to the point where it's used for planning and follow-up. Then you've got an architecture that can really empower radiology to be the curator of images, the deliverer of the service, to bring a really rich and valuable offering to the people who are actually the customers of radiology, the referring physicians. So yeah, it's definitely true that you need to focus on interpretation, but you also should think about the longer-term strategy and the bigger picture, because it's much more than radiology these days.
And Vikram?
My comment is on the integration. I mean, a right-click launch and launching different applications, even in a client-server format, that's great. It's a compromise, as Dr. Siegel said. I think where we need to head is what internally we refer to as viewport level, keyboard, and mouse integration, which is really giving advanced visualization images in your current unified viewer, whatever that needs to be. And that's where I think we all need to head to make the experience a lot better and a lot more seamless.
Yeah, but on the other hand, what we see, there is a desire for both worlds. Yeah, so we see a lot of customers who want to have that unified and integrated. Yeah, so with the same UI, as seamless as possible. And then there is other customers who clearly say, well, but I want to be able to make the decision on which vendor I choose for a specific, rendering purpose or advanced visualization purpose. So we will definitely support both worlds in the midterm future, to offer that flexibility.
Thanks. Do you have a follow-up to that?
A couple of comments.
Sure.
Very short. The first one is the needs of the clinician are very different from the needs of the radiologist. I mean, I think that should be obvious to everybody. They're very busy taking care of patients. They don't have time to fool around with 3D and specialized processing and so on. That's the radiologist's job. They want to see the results. Okay? So I don't subscribe to the fact that all the capability that the radiologist has also has to be out in the clinic area. They don't have the time. I mean, many of them have 30 seconds, maybe, okay, to look at a given study, maybe 15, while the radiologist has, depending on the study, 15 minutes, 20 minutes, whatever.
Yeah, I think that's absolutely my point. The radiologist, the value of the radiologist is to take that huge amount of information and distill it down to a finding. But a surgeon still has a value, they have value to extract from 3D interpretation. So if you can deliver that finding in context, in a package they can consume in 15 seconds, you've created great value for the radiology department. And that helps to reinforce the relationship, it drives referrals. So yeah, I'm not saying that they should have access to all of the universe of tools, but you should have some kind of common system driving that, such that the radiologist can create a package they can interpret. And that's why this architecture is very important. It should tie together. The delivery should be tied to the interpretation.
It's a very controversial topic also as far as who has access to advanced visualization capability. I mean, we have the capability of auditing in our enterprise exactly who is using the system, exactly when, and doing historic information about where it's being used in surgery, vascular surgery, et cetera. Once we released it to the enterprise, we found an incredible amount of utilization of advanced visualization. So if they only have 30 seconds, they're certainly spending that 30 seconds doing a fair amount of interaction with advanced visualization. Whether that's a good thing or bad thing as far as patient care might be debatable, and how different radiologists feel about that may be debatable. But at least in our experience, particularly among some of the residents and some of the younger non-radiologists, we're seeing a lot of utilization of maybe not all the advanced visualization functions, but a significant percentage of them. So I've heard in talking with other radiology colleagues different opinions about level of access that non-radiologists should have to the system. But I can tell you that based on the audits we've done, we've certainly seen people that have had more than 30 seconds of time to interact with the data sets. I personally believe that the radiologists should select the ones that are most representative. The radiologists and 3D lab folks should do the quantitative measurements and then send those out, and then allow the clinicians to make small modifications. For example, if you're looking at a cerebral aneurysm, to have the capability to be able to look at that from slightly different perspectives might be one example. But it's a really important topic to think about as you're rolling out advanced visualization.
Just to that point, when I attend a tumor board conference, I'm the radiologist there, but the neuro-oncologist is there, the neurosurgeons, the radiation oncologist, and their interest in the highest level of interaction with the 3D volumes that we're interacting with is really is awe-inspiring and humbling to me, because some of the images that we're making diagnostic reads were protocols developed in multi-center trials where those neuro-oncologists designed the imaging parameters that we're commenting on, and they're just as interested in interacting with those volumes. So more than 30 seconds in certain use cases. But actually my question was not so much what our capabilities are, but what should we be doing? Elliot, you did a phenomenal job in your introductory talk pointing out all the points of pain and excitement about the current state. One of the most exciting things is saving just the volumetric data and having the radiologist sit before almost a tabula rasa and deciding what to do to make their diagnosis and finish the report and move on to the next case. Right now, or in the recent past, it's just been whatever, you have to look at all the images. And some people decide, I don't look at the scout, or I should look at the scout. But now we're, every time I add another type of reformat, my clinicians, my colleagues in radiology are upset because they think they have to look at everything, especially dual energy. So the question is that how do we define what is the right thing to do when we sit before just a volume with nothing pre-rendered as the radiologist, and is it going to be important to track the radiologist's trip pathway through that volume? And when I use a thin client system, I'm amazed that I'm just sending mouse clicks to some server so far away, but that's actually a very small amount of data. Should we be saving that so that we know what the radiologist did? And in that case, also, what is our compensation or reward and punishment? If I may be rewarded for using more packages to make my diagnosis, or am I rewarded for making the smallest amount of interactions to come up with a diagnosis? And was it the right one, particularly in the case of where we don't know the ground truth, like what is the carotid stenosis measurement?
So that's a great synopsis of this really interesting topic. When we first went from film to filmless radiology, one of the questions that came up is, well, you can window and level essentially infinitely on the images, and do we need to keep track of the window and level that the radiologist actually looked at the data sets in? And now one of the questions is, for advanced visualization, should we save the session of what exactly the radiologist looked at? So do I have to be able to document whether you looked at the coronal images? If you're reading a CT of the abdomen, for example, some expert could come by and say, well, gee, you can, if you don't look at the coronal images, you could miss something, or MIP, et cetera. And then the other thing is, as I pointed out and you pointed out also, it used to be that we do a special CT that would essentially be a vascular CT if we were looking for vascular pathology in the celiac or mesenteric arterial system, or we would do a special spine reconstruction. And now every study routinely allows you to have that level of detail. And so just as happened with ultrasound, as time went on with ultrasound and the technology improved, our responsibility and what was the standard of care for reporting for fetal ultrasound changed dramatically from the 80s to the 90s to now. And is there some increased level of expectation for reporting things now that we have the capability to look at all those? And those have not been really determined, but they're interesting questions. Have you all had that, or I guess Brad first, has that been an issue for you all? And then I'd like to turn that to the vendors.
So I guess this is a little bit of philosophy of medicine in that if we now take it out of the realm of radiology, and when you go visit your primary care doctor, you have a long conversation. He doesn't record every word that's spoken in that conversation in his note, right? He says, here are the key points that I took out of it. So to me, we in radiology do the similar sort of thing. I think if we go down the route of we have to record every single pixel we looked at, that's going down the wrong pathway. And I think that part of our role as physicians is to say, I know, I reviewed the history, I'm aware of what I understand the clinical concerns to be, I reviewed the data set, whatever that means, here are the key things that I found out of it. Now, when you do a volumetric data set, in the same way that when they record the history, right, you got the HEENT cranial nerves 2 through 10 and 2 through 12 intact, all that sort of stuff, there are certain things that have been documented to be important when they do a physical exam. So I think when we do a radiology exam, there are certain things that we need to do And yeah, that bar probably ratchets up as we move into volumetric imaging, and we need to do evidence-based medicine to say, anytime you do a T1 weighted image, you always got to, the sagittals, right? You always got to look at the various components of the image. So I think that it's important that we establish what things need to be looked at in any sort of a data set, but I think to go down the road of saying we have to document every view we looked at under every window level setting, I think that's a losing battle for us to go after. And instead we need to look at what are the useful things to get out of the image and make sure that we extract that.
There was an interesting demonstration that was done a few years ago at RSNA that was called the completion cube. And so it turns out that now that we have volumetric data sets with thin section, if I'm reading a CT of the thorax, I don't even ever have to look at axial images. Maybe I just want to look at coronal images. And so it used to be that when people would reconstruct thick section CTs, I'd start at image 1, and I'd keep looking at every image until I got to the last image. But now there's no documentation of whether I looked in the coronal, sagittal plane, and so there's the potential, even in the axial plane, to not look at any images or to have certain images that aren't reviewed. And so one of the researchers had proposed something called the completion cube, where you'd have the volume of information, and then as you would go through the data set, it would color in which areas that you'd actually had seen, whichever plane that was in. And so at least at the end, you could know that you've actually looked at everything. For example, lots of us in the sagittal plane might just look at the midline through the spine, for example, and not look for other details. So there are lots of ways to be able to look at that issue that you're raising. And I agree with Brad. I really don't think it would be advantageous to the patients or radiology in general to audit every session of what every radiologist or clinician is looking at. But and the issues haven't come up medical legally. But I think it is a really important topic to think about. And should there be at least a minimum that is expected when there's review of a data set?
Right. And so what is that minimum? Right now, it's whatever whoever just sets the protocols decides to put on the packs. And
yeah. Well, one thing you could do would be to at least record the initial presentation state that was made. How do you all get questions from?
I mean, for us, it's not about recording sessions as much as how can AV vendors help us make sense of the large volume of data. I mean, the questions we get is, can you use your anticipatory automation techniques to detect anatomy so we can easily localize pathology, or can you use your anticipatory automation techniques to number ribs or number vertebrae, so when I'm reading a CT in the ED, I don't have to count those again and again. So it's more around that rather than saying, hey, I want to record my entire session. They want help in the software giving them help in not missing a pathological finding.
I think, I think it's very important. There's a couple of well-defined procedures in 3D systems, but only a couple. Apart from that, it's really a general-purpose tool that supports the physician's diagnosis, and it's the physician who has to take the responsibility for reaching their conclusion. So I totally agree. I think that recording in great detail the particular path that a particular physician took to get to a sense of confidence that their diagnosis was right, it's probably not going to be that helpful. And we really have to remember, I mean, just as you mentioned, that these are not system to system. There's variability in how they measure. There's a huge universe of information already. You talk about adding sinogram data as another source of another dimension. Really, there's far too much here, and there are not well-defined standard of care procedures. But what you do have here is a very useful general-purpose tool that helps a physician get to their diagnosis when they're dealing with massive volumetric data sets. And it's popular because there's a need for that, because otherwise, how do you handle the data? But the diagnosis ends up with the physician, and the physician is the person who says, based on the tools I had, this is what I think is going on here. And I think that's the only way you can really manage this.
Thanks for the question. We got a text question that's a follow-up of the point I was making about the variability from one vendor to another in quantitative analysis. So I was specifically mentioning the fact that, for example, at the Stanford Bake-Off or the Stanford show, they have vendors with the same data set, and they see differences in measurement. And so question number one is, if I'm doing a carotid stenosis quantitative analysis, should I have a standard of error? Should I say 78% plus or minus 10% or whatever that standard of error of measurement is? And how do I reconcile the differences for the same data set from one vendor to the other? And how can I, as a customer, make a determination of accuracy? Because we've seen, in the studies we've done at University of Maryland and others have done and have been seen at demonstrations such as Stanford, we see significant differences, not just minor differences, in the measurements that are made. So from the vendor perspective, I'd be really interested in some of your comments. How do you all feel when you see that the measurements that are made on your own systems are significantly different from those on other systems? I mean, there has to be truth someplace, or is it just that we're interpreting truth in different ways, or is it that your systems are more accurate than your colleagues' systems? And how do we as customers deal with that variability?
We always feel that everyone else is basically wrong. But assuming that we might be wrong, I think that the problem is there isn't a standard defined, and you could say this is the way you have to measure a stenosis, but you still don't know how the contrast was administered, how the images were acquired, what the body habitus of the patient was.
And that's true, but how about on the same data set? In other words, how do you explain the variability
when
I give you all the same data
people
set?
are tuning their algorithms to certain typical kind of test data sets, and they may be of different types, so there's many sources of that kind of error. So I think again, the point is those tools are there to support a physician in their interpretation process. You mentioned, could we say 78 plus or minus 10%? I think even saying, we found that...
All right, not only 78 plus or minus, but I can tell you when I use some of your systems, I'll get a stenosis measurement of 78.926534% stenosis. And is that plus or minus 1 millionth of a millimeter, or is that plus or minus, 10%?
But one of the big drivers of advanced visualization was coronary CTA, and we very quickly discovered if you go in with anything that's a percentage number up against angiography, you immediately get shot down. You can't say it's a 35% stenosis because an angiographer will go and validate it with a cath and say it was 33 and your system is wrong. So that whole strategy of using 3D interpretation as some highly accurate tool, the very use of CT to measure stenosis is not that well validated in the literature. So the strategy that's been working is, look, this is a technique that can help us call a mild, moderate, severe, or normal, or occluded vessel. And the gold standard is whatever the literature is currently supporting, which is angiography. So until the studies are done to validate CT and the use of 3D systems against how to measure stenosis, you're really shooting in the dark if you call any number, because there is no standard defined, and much as we'd love to have one, it just doesn't exist.
But what do I tell my surgeon who says if it's more than 70%, she's going to operate, and if it's less, then she's not?
But the surgeon who says that 70% came from NASCET, which was, for carotid arteries specifically, and done with angiography. So until the study's done with CT, the surgeon shouldn't be calling it based on CT. You just give them mild, moderate, severe, and then they need to validate it and make their own call.
Thanks. How do the rest of you?
I mean, I agree with that. I think, until the studies are done and there's literature available to back up the measurements done on CT, that's right, what Robert is saying, right. But more important than that is, if you do the stenosis measurement twice on the same system, do you get consistency? And that's where that's something that we can control. Our algorithms are the same data set or different data sets going from stenosis to stenosis, and at least that should be, reasonably the same.
Can I comment? I'm from Philips. I just want to add to what Jao is going to say, but we are quite under severe pressure from legislation as a vendor to actually start proving these things. I agree with Robert and with you that we don't like it, and we certainly need clinicians to cooperate, but the pressure is on, and it's getting worse. So we see, I can't repeating myself, it's there. I think it's a very difficult topic, and as Robert says, accuracy is dependent on many things in the chain, but still the pressure is on. So somehow we have to, as vendors, react. FDA requires it from us.
Should there be a standard phantom that's out there, for example, that everybody makes measurements on and ends up validating against, or is that not possible or practical?
The problem, of course, is, as Robert says, that there are many steps in the chain. If you do that kind of validation, you have to validate with contrast agents differences, with scanner differences, so it's a very, very complex problem. But as I said, legislation is hammering down on us, so it's going to be a lot of work, but we have to make steps in validating our claims and saying our accuracy is such and such under such and such. It's not what we like because it's very difficult, but it's going to happen.
Okay, I'm going to take my prerogative as a moderator here and say the official time has ended. If you need to move on to your next activity, feel free to do so. Here's the CE number. There were a couple of good comments that were texted in, and I'm going to throw those out there. One comment was, or question was, what's the potential for advanced visualization outside of the radiology department? My impression is that it's very great. You know, the saying that in the land of the blind, the one-eyed man is king, and people who actually do procedures and want to make diagnoses, this is the way they do it. The other comment was that a person's wife was a nurse practitioner for a vascular surgeon, and their impression is that radiology doesn't really understand what they do. And my impression in working with non-radiologists is that that's very true, that when they think about, for instance, putting in an endovascular stent or aortic graft, that we don't understand, you know, first of all, there's the preference. They really like this vendor's graft or something like that. That's not something that I as a radiologist really understand. And so it's important that you work with the proceduralists who say, gosh, you know, that one rib is really low. I'll bet no radiologist dictates how low the rib is, right? So they have come to it with a different perspective, and the greatest value is when you integrate our diagnostic skills with their perspective of, gee, this patient is really obese, and you know, I'm going to need to do something different because of that. And so I think integrating that and engaging the non-radiologists who may be doing procedures on these patients is critical. So I'll throw that out there as a comment, and again, if you need to move on, I'll invite you to do that, but I'll throw that as the last comment.
Yeah, I'd love to comment on that because we had a conversation earlier about the role of radiology and radiology's customers, and I just would say we have quite a bit of experience of that, and vascular surgery is one good example. I've almost never seen that to be really competitive. The diagnostic interpretation is a totally different perspective from the planning and follow-up perspective of a surgeon, and they're complementary. They can help each other out. It's just great mutual benefit if everyone gets together on these images. And I think my personal feeling is that we shouldn't be afraid of embracing that, because informatics is what's going to control the delivery of these images, the access to the images. So imaging informatics can take control here of how these images are used in the enterprise, and it's a great opportunity and we should embrace it.
I agree to that, and I think reality shows us as well that this is happening anyways. When you look at utilization in your systems, I think we heard that a couple of times. You can see that other specialties are using the advanced visualization tools heavily and for good purposes, probably not for the same purpose as the radiologists. But that remembers me actually a little bit of the big debate on who is going to do actually the cardiac CT itself. Is that going to be in the realm of cardiology, or is that going to be in the realm of radiology? And I think what we see today, and I think you can compare it to the advanced vis applications, what we see today is that they actually, in many institutions, they work together and collaborate very closely. Sometimes they even sign the reports together. And I think that is exactly, we should embrace that because it's to the benefit of the patient.
Yeah, I agree as well. And actually I have some examples of a customer in Metro Hospital in Cleveland where he actually used the 3D state actually to guide the surgical procedure. So he has like one of our clients on the surgical room where he can really rotate the 3D data to guide the orthopedic procedure. So I think it's very important as we move forward with advanced visualization to enable those solutions really in remote places, and it could be inside the hospital, in the surgical room, and even outside the hospital.
So, I mean, I agree as well. I think, you know, the customers of radiology, clinicians, and especially surgeons, they look for positional information. Where is the feeding artery or the draining vein? And there is no better way to show that than in 3D. They really, you know, are the people that really need 3D and advanced visualization techniques, and the images that are generated by radiology to be distributed to them so they can view easily.
All right. Thank you very much. I appreciate your attention. Great questions. I want to thank the vendors for participating as well. If you have further questions, I'd encourage you to pull them aside either here or down in the exhibit hall and ask them the questions about their products as well. Thank you.
Thank you.